Good afternoon, everybody, and welcome to our 29th iGeriCare live event. We are so fortunate, as always, to have my teammate and collaborator and co-founder of iGeriCare, Dr. Richard Stramko, joining us from Hamilton Health Sciences today. Thank you for joining us, Richard.
Great to be here. Good to see you again.
Great to see you too. So today's topic is kind of a deeper dive on one aspect of the assessment of dementia that I think there's a lot of misunderstandings about. And so today we're going to talk about brain imaging. There's a little bit in this about this topic in our lesson on what is dementia, because we talk about some of the ways in which dementia is diagnosed. But in brain imaging, there's, diagnostically, there's currently no single test that we can use that can accurately diagnose dementia. So as we've talked about, dementia is, a complex syndrome. There's a lot of different types of conditions that may cause dementia. And so a detailed medical history, a physical examination, a neurologic examination, often we mention different types of cognitive tests, pencil and paper tests that might be done. And then there might be laboratory tests, and in some cases, a brain scan. So we'll talk a little bit today about some of the more common types of brain scans. And why don't we just start there, really saying, what in your practice, Richard, what are the most commonly used brain scans? And then we'll talk a little bit more about why somebody may or may not get a brain scan ordered.
Yeah, absolutely. So a CT scan, often referred to as a CAT scan or computed tomography for the radiologists in the crowd, would be the most common scan that we use. It's readily available and it's quite easy to go through the process of getting. So when you think about like a donut scanner, it's not an enclosed or small space, and people can be taken through that scanner quite quickly, maybe 10 minutes or 15 minutes, and have a fairly detailed assessment of the brain. It's very good at picking up bony structures, and it's fairly good at looking at the brain, but there's some limitations in that the soft tissues and the atrophy patterns in the brain might not be picked up quite as well. But because it's very easy to do, it doesn't take a lot of time to do, and the CT scanners are readily available, it's the fastest test to get done to rule out any major problem. So, ruling out a big brain tumor or ruling out significant strokes. It's quite good at that. The second,
I think that's a really good aspect of it. A lot of times the brain imaging is not necessarily to confirm, we think you have this type of dementia. It may be to rule out other medical or neurologic causes of symptoms that look like dementia. As you mentioned, is there somebody who has had a bleed to the brain or a brain tumor? And the CT scan is a good tool to potentially make sure that none of those other conditions are affecting somebody's memory.
Absolutely. And I think we've talked about, you mentioned the history that people tell you in terms of their symptoms, hopefully aligning with the lab tests, aligning with the physical examination, and then finally the imaging. And so it's just making sure that you're not missing something that's otherwise there. So kind of an anecdotal story would be somebody who I thought had for sure just run-of-the-mill Alzheimer's disease. The one thing that was slightly atypical, so they had short-term memory problems, executive function problems. It was generally slowly progressing over the course of 2 to 3 years. So nothing drastic or dramatic. They hadn't complained of any neurologic symptoms, but there was a reflex that was slightly abnormal, which suggests that, there could be something wrong in the spinal cord or in the brain. And because of that, we got an expedited CT scan, and there was a benign tumor called a meningioma there, meaning it's not going to aggressively spread. But in the place where it was, it did cause a bit of swelling or edema in the brain, and that seemed to be causing a lot of the cognitive problems that person had. So it's always useful to be certain, especially if you're going to be giving somebody a diagnosis as serious as dementia and as life-altering. You wouldn't want to miss those other things.
I would say the other thing that we see quite a bit in the hospital setting is somebody who maybe has been labeled as having some cognitive impairment, but maybe it's been happening slowly. And then they present perhaps after a fall, and it seems like their cognitive impairment has gotten a lot worse very quickly. And that's the type of setting where somebody might worry, did they cause some type of a traumatic bleed to the brain when they fell, or is there something else going on, like a bleed or a stroke or a tumor that might have even led to this more rapid decline and possibly the fall as well? So again, using the CT scan in a sort of more urgent type of situation to make sure there isn't something else going on that might be causing the cognitive impairment. And so that CT scan is an X-ray, and we'll look at some examples in a little bit. But it's a specialized X-ray of the brain that gives you some information, but of the structure. And I think that's the other thing, that most of the brain imaging things that we use give you a structural visualization. In other words, they show the structures of the brain. They will talk a little bit about some of the other types of brain imaging that are less commonly used that may show you a bit more about the function of the brain. But there's no sort of magic brain function test where, and again, with the CT or even what we'll talk about, the MRI scan, it's rare that you sort of do the scan and you can say definitively, this is absolutely dementia. So it's still all of these things taken together with the history, with the physical and the neurologic exam and the testing. They go to support a diagnosis, and you can say maybe it's a probable Alzheimer's disease or a probable vascular dementia, but they don't definitively diagnose anybody. So let's talk a bit about MRI then. Tell us about that.
Sure. So that's magnetic resonance imaging. And so they use powerful magnets. And I'm not very technical in that sense. You talk to a physicist or a radiologist, but using complex computer calculations to look at the differences in between magnetic fields. They can do all sorts of different calculations and use the magnets in different ways to produce different types of pictures. I think most people are familiar and have heard about this, but it requires you to be in quite a long and narrow tube for a period of time. And so people can feel quite claustrophobic in that tube. It produces quite a significant amount of noise. And so you'll be inside of this area and people will be speaking to you through headsets. Or speakers so that you can hear what's happening, but there's lots of loud banging and clanging and you're in an enclosed space. So that does limit its use sometimes for people that are severely claustrophobic or people that are severely cognitively impaired that can't sustain attention for that period of time, or that can't understand more complex instructions in terms of when to breathe in and breathe out, because they do require that you stay quite still for long periods of time and hold your breath for various scenarios. A little bit less with the brain, but some people may require sedation if they're very anxious, or other approaches, as you say, to try to have a scan. And if you move around too much in any of those scans, you can get what's called motion artifact. So it's very hard to interpret the scan if there's too much movement. So it does rely on a certain amount of cooperation to get those things. So the upsides, I mentioned a bit of the downsides. The upsides are that you get much better pictures or resolution of the soft tissues in the brain. So if you're looking for very subtle shrinkage or atrophy patterns, they're much easier to detect with the administration of something called gadolinium, which is a contrast agent. You can pick up subtle inflammatory changes. So if there was inflammation in the blood vessels in the brain or other autoimmune conditions, and even smaller tumors, with the enhancement of the gadolinium, you can pick up in a more sensitive fashion on MRI more illnesses or disease states than you ever would be able to on CT. And then with all of the different picture types, in particular would be a DWI sequence for Creutzfeldt-Jakob disease or the more rapidly progressive diseases, you can see very specific findings that can aid in your diagnosis, all of which you would not be able to see on CT scan. So
yeah, we don't want to get too technical, and we'll show some examples, but due to the magic of some of the physics of this, there are kind of like different settings that allow you to visualize different brain structures through the same MRI scan. But depending on the different techniques that are used, it may really help to clarify different conditions. And it's really, as we'll see from some of the examples, the level of detail that you can see of the structures within the brain is quite a bit better with MRI, but also harder to access, and those other limitations that you mentioned as well. So before we look at some examples, maybe just can we talk a little bit about, what are some of the indications, or why would somebody get a brain scan ordered? And then what are some of the scenarios where you would not necessarily order a brain scan? Because I think that's sometimes confusing for people. They may, receive a diagnosis of dementia, but they're told that, no, we don't need you to get any other tests. And when would you order an MRI versus when would you order a CT scan, for example?
Yeah, and I think we mentioned this on one of the live events, either the last one or maybe perhaps 2 live events ago, and that this has been a bit of a moving target. So when I was in my training for fellowship 10 years ago, we would say you only really have to order a CT scan if somebody's had more rapid progression, or they have neurologic exam abnormalities, or they've had seizures, or a personal or family history of cancer or something like that. But it has changed over time to the point where neuroimaging is recommended for everybody, regardless of their age. So at least getting a CT scan and MRI is preferred. But that being said, some people are very frail and have a hard time perhaps getting out of their long-term care facility, or perhaps a hard time traveling around between different appointments, and their dementia is not necessarily their biggest issue. And it's quite a challenge to get them back and forth between appointments. And if somebody in that situation gives you a very classic history of slow progression, and there's been no change to their neurologic examination, and there's been no history of other findings that would make it concerning, you've done your blood work panel, you can have a conversation with the family and with the person that has dementia at that point in time, and ask them, is this something you're really interested in pursuing further, or do you kind of have bigger issues or bigger fish to fry at this moment? For most everybody else, they should get at least a CT scan. The challenge between the CT and the MRI, again, is the availability, and whether they have any of those other findings or symptoms that suggest any kind of rapid decline. And I would also say it is more applicable to the people that are not quite so impaired, but age is sometimes a factor in that, and how many other conditions they have. So if you have a very clear history and story, and again, none of the other red flags, and you've got a CT scan that's not really showing anything that's that abnormal, then you could stop there at that point in time, depending on what the patients want. The additional things that you're looking for that the MRI would definitely help out with, obviously, is the atrophy patterns. Sometimes that's not needed. And then blood vessel disease. So small blood vessel disease is easier to see on MRI. And then there's always something called cerebral amyloid angiopathy, which is also a bit easier to pick up on as well. So
yeah, let's walk through. I'd like to walk through some of our visuals. And as we're walking through some of the visuals, I'm going to pull in some of the questions that are coming in that are maybe relevant to some of them in particular. So, and I guess we'll apologize a bit in advance. We're both going to rein one another in terms of getting too technical or detailed, because in the more general perspectives that we've just talked about in terms of what are the tests, when might we order them, when not, I think that's the helpful type of information. But I think I feel it's also helpful to look at some of the scans to appreciate what you can and also what you cannot necessarily tell from the scan. So we'll start off, just as you mentioned, the CT scan. It's, if you've ever been for an X-ray of a body part, it's not altogether that different, except it's your head that's going to get scanned. The MRI machine is definitely a little bit more enclosed. We have talked about in our lessons the different areas of the brain, and depending on which areas are most affected by the cause of the dementia, that might determine the symptoms. This is sort of a illustration from the side. It gets a little bit, as I was saying, you can see different kind of slices or planes depending on whether you're looking at a slice going this way or a slice that might be looking at, the brain from the side or from the middle, or ones that might, look at this angle. So you can often see three different main perspectives with both CT and MRI. This is an example of a CT scan, and this would be starting at the back. The nose is at the top in this view. This is starting really at the base of the skull, so you can actually see the spinal cord. The white stuff is bone. So this is all the bone of the sinuses and the skull. As you move up, you see the skull around the outside, and you can see the eye sockets and the eyes at the front as well. So it's as if you're standing at the foot looking up at the person. And this is sort of gradually moving up in roughly 5 millimeter or 10 millimeter cuts that are going up from that. We often look at these ones that show important structures. They also tend to show whether or not there has been atrophy relatively clearly. This is a normal brain. So you see how the brain really fills the whole of the skull. And the black part in the middle is the ventricles where the cerebral spinal fluid goes. Often if people have atrophy or even some other conditions, those ventricles look quite large because the brain tissue has been shrinking. So the ventricles get a bit larger, and we'll see examples of that. And then it continues up. This would be like the top of the head where it's mostly the thick skull bone is getting thicker again. This is also a CT scan, but whereas the other one showed, sort of the cut going this way, this is showing it from the side or the sagittal. So again, you have the nose and the eyes and the mouth, and this is the skull bone, and this is the brain fitting in there. This is actually other parts of the brain leading to the spinal cord. And this little part at the back is the cerebellum. Just like we showed the different parts of the brain, this is an MRI scan, but again, you can see, the frontal lobes quite clearly. You can see areas like the parietal lobes or the temporal lobes. And we often do look for particular structures that might be affected. As you can see, you can really visualize the brain matter itself quite a bit more clearly in an MRI scan versus a CT. This is, again, a nice MRI, similar to the one I was showing before, where we could look at those ventricles. And this is the lateral ventricles. This is the back part of the ventricles because it runs through. This is also normal, but this is also just to illustrate what you were talking about before, that you might have different techniques to visualize things. So this one is what we sometimes call the T1 or anatomical view, because the gray matter is gray along the outside and the white matter is actually white, and the cerebral spinal fluid is dark. In this different technique, you actually can visualize things differently. And some things like white matter problems or vascular disease, you visualize quite clearly because the white matter in this view is dark. And if you have different lesions, small strokes, things like that, they tend to appear bright white on the scan. So let's talk a little bit about a few of the conditions that we sometimes look for. Sometimes the CT is used. In the United States, if you show up at a top hospital and it looks like you're having a stroke, you would more likely now, I think, at many hospitals get an MRI where they use particular techniques, because sometimes the CT scan for certain types of strokes won't show anything initially. It's harder to see unless it's a bleed. However, if you've had a stroke in the past, this will show up quite fine on a CT. So sometimes when we do a CT, we may not know that somebody's had, strokes in the past, but you can actually see, especially larger strokes, you would visualize on a CT scan if they were older. This is something that you might see if somebody came in and had acute symptoms, and in this blood that is new appears sort of bright white on the CT scan. So sometimes that's an important part of getting the CT scan, especially if there's been a new change or somebody's coming to the emergency after a fall or passing out. We're really looking to make sure there hasn't been a bleed. Do you want to speak to this at all? Because this is a condition that we do sometimes see. It's an important one to rule out. Maybe speak to this a little bit, Richard.
Sure. So normal pressure hydrocephalus it's fairly uncommon condition. So you don't see it very frequently, but as opposed to hydrocephalus where there's actually a pressure problem. So the black part that you're seeing there are the ventricles, the lateral ventricles, and those are always filled with cerebrospinal fluid. Sometimes if there's a plug or blockage or a tumor is blocking something, you can see them fill up with that fluid and there's increased pressure in the brain, and people will have quite significant symptoms. And you can see, with respect to headaches or cognitive changes that happen quite rapidly, or deterioration in their ability to walk or speak. Whereas normal pressure hydrocephalus happens over a long period of time, and we're not exactly sure why it happens, but the ventricles enlarge and people would present with a dementia, so cognitive impairment of a kind of subcortical type, urinary incontinence, or even increased urinary frequency or urgency, and walking problems or gait problems, otherwise are most typically referred to as magnetic gait, where they can't quite get their feet up off the ground, and there's not quite shuffling related to Parkinson's, but they just have a hard time moving their feet. And sometimes they don't even have the typical findings, but looking for some combination of those three elements in combination with these enlarged ventricles, where you can lose the curvature. You've seen it on the other scans. There's quite a nice curvature, and they appear to kind of flatten out and get bigger.
It's not always, as you say, it's still relatively rare. If you can kind of diagnose it, it has treatments associated with it that can reverse it. But it is also hard to tell sometimes if somebody has really severe atrophy from dementia, because the ventricles will also grow larger. So it's not always easy to tease it apart. And some of you may have had the experience of people saying, maybe this could be normal pressure hydrocephalus. We're not sure. So they may or may not do a test where they try to relieve some of the fluid from the brain.
I think in this situation, so for the scenario you're describing where there's lots of brain shrinkage on the outside of the brain and the ventricles just naturally fill the additional space, you're looking for a lot of blackness around the outside. And in this particular scan, you can see there's not a ton of black around the outside of the brain. So this is much more concerning. So in this situation, you would do the intervention where you do a spinal tap and try and drain off quite a lot of fluid to relieve the fluid overload. And sometimes people improve quite substantially and can go for a neurosurgical procedure to actually reverse some of the cognitive impairments, sometimes all of it, and improve the walking symptoms. It can be very gratifying to treat. It's not often you have these reversible causes.
So here's another potentially reversible cause, but again, the reversible cases of vitamin B12 deficiency are still relatively rare. But this is one of the circumstances where an MRI is quite a bit more helpful than a CT scan. This is a particular technique, but you can see where it's been circled here, there are some little white dots in the white matter. This one at the bottom here is even a little more prominent. So if left untreated, the vitamin B12 deficiency causes a condition called demyelination, which is basically the white matter begins to have serious problems. And conditions that affect the white matter are nicely seen on MRI compared to CT. And I want to use this as a bit of a segue into one of the questions that came in. This is somebody who said, I'm interested in white matter disease, which can be detected on imaging. What does it mean to have white matter disease in relation to dementia? Does it mean that people who have a certain type of dementia, like vascular or Alzheimer's, and if so, which one, or can it vary widely?
So the white matter, it was very clearly displayed on that T1 image T1 MRI image that you had up earlier, but it's basically all of the connections. So there's the cerebral cortex that have very specific functions, all the gray around the outside, and you can see the white matter there, which connects all of the different parts of the brain, one to another. So you'll have your frontal lobe connected to your basal ganglia and connected to your thalamus, and it even flows down into your spinal cord. So very, very important with respect to function. Usually it's more disproportionately impacted by vascular disease. So whether you've had a stroke in the subcortical regions where the white matter exists, or you've had the small blood vessel disease or microangiopathic disease we talk so much about. So vascular disease is much more likely to impact those areas than other neurodegenerative conditions, although they can. And then something like alcohol as well disproportionately impacts the white matter when compared to other neurodegenerative conditions like Alzheimer's. So
I guess it's also fair to say that we do sometimes also see people who have white matter lesions without it necessarily indicating a specific disease. But, again, if somebody is presenting with signs and symptoms of dementia, and they also do show substantial white matter disease, you would want to better understand that. I do have some other examples actually of that. So I
think that's a great point. It's quite common to just have a brain scan that displays some form of aging-related small blood vessel disease. And it's only when you're having the history match up with the physical and match up with the brain imaging findings. So that's always an important point. It's never you look at a scan and you've got a diagnosis.
That's right.
You have to take it all together.
We'll come back to that point when I show a couple of the other examples, because I do have some other examples of vascular disease showing kind of white matter lesions. This is one of the other things that we are looking to rule out, which is a brain tumor. In this case, there's that sort of fairly large spot here that represents a brain tumor, and it's one that again, sometimes these brain tumors do grow quite large before people might even have symptoms. This one is grown large enough that it's actually putting pressure on the other parts of the brain. It's caused the so much pressure that the ventricles are getting small. Sometimes the pressure is such that it will actually block a ventricle and cause even greater rising of pressure. So, looking for tumors it is definitely one of the things that people are doing when they're ordering a scan. So, just a few examples. So this is a CT scan in the different orientations, and part of what it's showing is that atrophy. So whereas some of the other examples we showed really filled the whole of the scalp, here you've got areas where there's lots of black, as you were describing before. These areas are shrunken or atrophied. So there's more space in the different areas here, whereas this would normally fill the whole of the scalp. And same, even at the top, you can see there's a lot more room in this bottom one. So that this shows just kind of atrophy from that standpoint. Let's see I must clear my drawings. This is an example of somebody who's showing both atrophy on their MRI scan, and they're also showing some of the white matter disease that we talked about. So this is a good example of, here's where we're seeing the shrinkage and these spaces that indicate atrophy. And that's something we would see with Alzheimer's disease. And then we have these white lesions in the white matter. So those are suggestive of somebody who might have a mix of an Alzheimer's disease with the generalized atrophy, as well as possibly a mixed with vascular changes. I don't know if you want to speak to, this is another MRI of somebody who's been diagnosed with vascular dementia. And I think you can see on this one, there's a number of these little white matter lesions that represent a series of small blood vessel disease. So.
And this is just a cut that's a bit higher up in the brain. And this is what white matter tends to look like when you're a bit higher up. When we're a bit lower down before and had most of the ventricles, you could see at the capping. So at the very front and at the very back of the ventricle is where you're seeing most of the white matter changes. And then the other thing I would say is there's, on the last scan there, just the previous one, Anthony, is, there are lots of black areas where the white matter should just be completely together. And so sometimes, and the radiologist will read this out, when there's a lot of those tiny holes in the subcortical areas, those do reflect old tiny strokes.
Yeah.
Sometimes they could be blood vessels, so you need to be careful not to get fooled. But when you see that many tiny dots or tiny black dots in the area where you're supposed to be seeing gray, then that's also highly suggestive that you've had some further vascular insults there, which also impacts your cognition. So this is, they've got the full house of badness happening here using my highly technical language.
So I'm going to read one of the other. This was somebody who sent in an MRI report, and I think there's some similarities between the scan that we're looking at and some of the things. So we're not going to, I guess, comment specifically in detail about this MRI analysis, but I will read some of the key components. So one, it says there's no evidence of mass effect. And previously, when we were looking at the MRI of the brain tumor, we talked about the mass effect where it might be pushing. So in this scan, the ventricles look normal and there's no mass effect. And then they describe mild to moderate cerebral and cerebellar atrophy present. I would say the scan that we're looking at the picture of now, this is a more pronounced. So this is probably, beyond moderate cerebral atrophy. This scan is higher up, so we can't see the cerebellum on this particular cut. The cerebellum would be below this, but this is, I think, what most radiologists would call severe atrophy. So in the example analysis that the person sent in, they talk about mild to moderate. Slightly greater left-sided temporal lobe atrophy noted as compared to the right. So again, they're commenting this scan also has a bit more left-sided. Remember, the right-hand side of the image is the left side of the patient, and because it's like we're looking from the feet. So this one also shows a bit more left-sided atrophy than right-sided, in my opinion. But again, I'm not a radiologist, though I really wish I'd become one because I like it so much. There are multiple small round foci of bright signal in the periventricular deep white matter, not associated with any restricted diffusion and representing several old small vessel infarcts. So that's maybe something a bit like this. That is, again, there's bright signal indicating damage, but what it suggests, I think, is that there might be more that are a bit like this, that they might be more of a discrete, small lesion that suggests a small infarct and not necessarily, confluent ones that have come together here. So they're more like
the next image that you had was probably like exactly what they were talking about in terms of those.
Yeah, exactly. These kind of small ones that probably indicate individual small vessel disease.
And sometimes, there are situations where you could have, let's say, a blood clot that's in your heart that breaks up and showers to several parts of the brain. So you had one clot becoming several clots. And in those situations, you can see the restricted diffusion, which they're mentioning, which means decreased blood flow. And if you had that, then you'd say these similar pictures might not be an old stroke, but they might be a new stroke.
So the bottom line interpretation from that one was the mild to moderate atrophy, slightly more advanced at the left temporal lobe, multiple old small vessel infarcts noted in the deep white matter. So, again, clinical correlation is totally required here, but the scan might have looked something like this. And, again, depending on the history, it might suggest a mix of something like an Alzheimer's and a vascular dementia, assuming that the history is suggestive of a dementia.
I think that's a bit atypical to point out there is just the cerebellum being involved.
Yeah.
That's not typical for our Alzheimer's, dementia with Lewy bodies, vascular patients, frontotemporal dementia patients. So
that's an excellent point.
There are neurodegenerative conditions, spinocerebellar ataxias can have some cerebellar atrophy, and then probably more commonly in alcohol patients is alcohol.
And also a lot of different medications that can also cause it. So if the person were on some of the anticonvulsant or anti-seizure medicines for some time, or other mood stabilizer drugs will sometimes cause atrophy of the cerebellum. It might not be part of the same process necessarily, but you're right, alcohol, which is next live events topic, I believe, is one of the more common causes.
I'm spoiling everything now, then I just keep quiet.
I want to get to a few other, we talked in our module about frontotemporal dementia. Here's a CT scan. And again, it's showing basically a more pronounced atrophy in the front part of the brain and in the temporal regions. So that's an example of that. Let's talk briefly about functional brain imaging. And we have a question. So tell us about SPECT, and then tell us about PET. Because we actually had one of the questions come in saying, are PET scans useful in diagnosis?
Right. So the main difference between SPECT and PET. So there's positron emission tomography is PET. That's usually based around glucose metabolism and just looking for areas of high metabolism or glucose usage or areas where there's not a lot of glucose usage. And so if parts of the brain were damaged and not using that glucose, then you would see the specific areas compared to others not using glucose and say those areas are damaged. And if there's a pattern that shows that's consistent with the front of the brain in frontotemporal dementias or the back of the brain, then you could come up with a more narrow conclusion. In this situation, so SPECT scanning involves perfusion, so labeling the blood to see what's actually perfusing or not, or if there's good blood flow to those various regions. So you'll see the yellowish orange areas are the areas that have normal blood flow, and the purple areas where there's not that orange suggests low blood flow state. So you'll see that the temporal lobes that you're pointing to right there are much more consistent with Alzheimer's. And in the bottom row of pictures, you'll see the back part of the brain being more preferentially impaired with low blood flow than the front. So in this situation with poor temporal lobe and parietal lobe and occipital lobe atrophy, poor perfusion, you'd say, wow, this is much more consistent with Alzheimer's disease. Where this is helpful, we find, is when the picture is not completely clear. Somebody perhaps is presenting 50s or 60s and it's a bit more of a rapid progression. You've gone through everything else. You've got MRI, you've done your LP, done a bunch of blood work, and you're still not sure. This can kind of give you hints or clues. The other thing is I've had people present with behavioral variant frontotemporal dementia symptoms that are a little bit more rapid or slightly atypical because perhaps they're older, and you'll get a SPECT scan and it will show prototypic classic Alzheimer's findings, which just suggests that the beta amyloid and tau is spread out a little bit more in not so typical fashion for Alzheimer's disease, but you can narrow it down for the family a little bit, the family and the patient, and they find that helpful, kind of knowing that you've done everything. But generally it's reserved for the more atypical cases, at least here in Hamilton and throughout most of Canada, just because it's more expensive. And with the PET scanning, we use tons of PET scanning now for cancer diagnosis and management. And it's quite hard to get. It's a very limited resource. So we don't really use that frequently in our practice day to day.
Yeah, I would agree. And there's one other modality here that I have labeled as Fmri or functional MRI. And that is still largely used for research purposes, but it's basically taking the detailed sort of structural image of an MRI and superimposing a functional molecule. So a bit like the SPECT and the PET are representing function, whether how much blood supply is there or how much glucose the brain is using in different parts. The functional MRI kind of weds those two technologies a little bit, but it's not really used diagnostically or clinically. It's pretty much reserved for research at this point, I would say.
I think fMRI has probably taken our understanding of the brain in terms of what areas do what to the next level, as you're referring to. So when somebody's in the MRI scan, they're actually having them do tests, whether it's complex executive function tests, and they'll be able to see, the dorsolateral. I'm getting too technical, but you do the tests, you see the areas that are lighting up while you're doing those tests, whether it's speaking or more executive function testing. And you can actually in real time see, which areas of the brain are responsible for those various cognitive functions. So that's really interesting.
Yeah. And I would agree with you. In our centers, we tend to use SPECT more than PET for the diagnosis of dementia. And again, it's certainly not a first or a second kind of go-to imaging thing. It would be, more like, hey, we're not sure if there isn't, we need greater clarification here. I want to read a couple of stories that came in from readers just before we wrap up. This was from a caregiver who talked about the memory of her spouse slipping away, and he was also having visual spatial issues, losing his sight and having trouble with visual cues. But she comments that I keep him busy gardening, cleaning the kitchen, doing the laundry. Yes, I could do it, but it's good for his brain to do these things. Just recently, I've hired help 2 hours a week in the house and 2 hours a week in the garden. He believes he's in charge and still useful, and I believe that's important. I found a volunteer male friend he talks to every week and shares story about boats and cars. I have a volunteer whose husband had dementia, and we can talk about the situation and debrief. And so far, it's working. So I really like to share these stories. I want to thank our, loyal iGeriCare people for sharing their stories. And I think it's really helpful for people to hear different ways in which people in the community are, trying to creatively meet the challenge of living with dementia and living as a caregiver. Here's another one. It's kind of not related, but my family thinks my husband depends on me too much. I have a fairly good memory, so he tends to just ask me for the answer. They want me to put more responsibility on him to think. How can I do this without annoying him? I don't think there's really one right answer or approach in this kind of case. I think, it's really important, no matter what the level of cognitive impairment, to keep somebody engaged and as much as possible and to the best of their ability. There may come a time when, this may be suggesting, like the fact that the person is turning to you more may be suggesting that they are having more challenges cognitively. So yes, it's important for people to stay cognitively engaged, but you also don't want somebody frustrated because they're being asked to remember things that they don't remember. So I don't know if you have any other suggestions about this vignette, Richard.
I think you've covered it. It's really, I'll stress people in terms of the opposite direction, and that putting people in scenarios where they don't have the processing capability or ability to keep up with conversations, or giving them more than they can handle will result in the frustration that you're talking about. So oftentimes people feel a bit liberated when they understand that. It's like, there's only so much that they can do, and just finding that appropriate balance of treating somebody with respect and dignity and providing them, as opportunity to exercise as much autonomy as they possibly can in their lives, while at the same, not trying to protect them from everything. While on the other hand, not overwhelming or overburdening with somebody when their brain just can't work in those sets of circumstances anymore. So,
yeah, no, that's well said. I'm going to finish off with sort of a summary question, just to kind of bring together some of what we talked to today. And the question that came in was, can you see dementia on a brain scan? And I think what we talked about today is it's important in many cases for there to be at least one brain scan to sort of make sure or rule out other potential causes of cognitive impairment, memory, or language problems. In other words, make sure that there isn't a tumor or a bleed or something else going on. You can't necessarily make a definitive diagnosis of the cause of a dementia just from a brain scan. We do use both CT and MRI to rule out causes of cognitive impairment, but taken together, the findings on an MRI or a CT scan might also go in some ways to confirm or align with the probable diagnosis of dementia. So you might have thought that the picture was, in terms of the history and the neurologic and the physical exam, was suggestive of a vascular cause of dementia. You might then do a scan and see multiple strokes or multiple small blood vessel disease, and that would be suggestive or somewhat confirmatory of the probable vascular dementia. So you can't necessarily see dementia per se, but you can use brain imaging as one of the investigations, along with the history and the physical and the neurologic exam and the time course of the illness as well. Any other final comments about brain imaging from you, Richard?
No, I think it's, I think, as people can see, it can be quite complex. There's lots to it, and it can be quite nuanced in terms of the approach. You don't want to be overly technical, overly scientific with too much. And you want to be comprehensive in your approach, make sure you're not missing everything, but have a tailored approach depending on where people are at in their overall dementia journey and what their wishes and goals are for the time that they have kind of remaining here. So
yeah, that's the other important bit. And I think you mentioned it about, somebody who may be very frail or have other conditions. Will the brain scan change the management approach or make the person's life better in some way? So that's another important, rationale. We don't usually order tests if it's not going to change something in terms of the management of the issue. So,
yeah.
All right. Well, I would really like to thank Dr. Stramko again, as always. iGeriCare was developed with support from a number of key people, including the Canadian Centre for Aging and Brain Health Innovation, or CABI, powered by Baycrest. We're fortunate to have support from the Jarrah Centre at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, the Alzheimer's Society Foundation for Hamilton Halton, and our Division of E-Learning Innovation team, who have made this work. I, once again, just as a final point, we encourage you to donate. From the homepage, iGeriCare.ca, there is a donate button there, and 100% of the donations go toward continuing to bring you live events and updates to our lessons. There is a survey pinned at the top of the comment section. Our next live event is scheduled for Wednesday, October 13th at same bat time, same bat channel, 1 p.m. And we'll be talking about alcohol-related cognitive changes and alcohol use disorder and dementia. So once again, thank you all. And as you know, teamwork makes the dream work. We'll see you next month.